Hello class, this is Ms. Gefeller. Welcome to Chapter 25, Asepsis and Infection Control. This chapter relates to Program Outcomes 3 and 4 and Course Outcomes 6 and 10. Before we get into the details of how to care for someone with infection as a nurse, we need to have a little background on what creates infection. So we're going to start with the infection cycle. So I've used this image courtesy of the Texas Department of Health and Human Services, and I chose this image because it has visuals to complement the text. And your textbook has a good explanation of this as well, so please refer to that. But the first part is that we have to have a pathogen, and a pathogen simply means something that can create infection, can be a problem, and we have different types of pathogens. So we're going to get into some more details on subsequent slides about what those pathogens are and what their names are, but just in summary, they could be bacteria, viruses, fungi, or parasites. So after there's a pathogen, that pathogen has to live somewhere, and that's where the reservoir would enter in. So the reservoir is where the pathogen is residing. Now this could be in contaminated food, it could be in contaminated water. Animals can be a reservoir for things like a virus or a fungi. And then, of course, people, especially sick people, could be a reservoir for infection. Next up is portal of exit. So there is a pathogen, it's living somewhere, but then it has to get out of that reservoir in order to travel somewhere else. And that portal of exit is how the pathogen exits the reservoir to go on to its next victim. So most commonly in healthcare settings, we're going to see that emesis, so vomiting, coughing, blowing your nose into a tissue that's all snotty then with mucus, things like that would be the way that the pathogen exits the reservoir and then is sort of open season for being transmitted. Next up is mode of transmission. So different types of pathogens are going to be transmitted through different means. Some of them require direct contact. So that would be, you touch someone with an infected wound and you're not wearing gloves, there's a chance that infection could get onto you because you had direct contact. Indirect contact would be, let's say someone sneezed and they had flu type A. Those flu virus particles could be in the air and could get on you sort of indirectly, or a vector could be, maybe you touch something that a sick person touched. They coughed onto their hand, they then touched the door handle, and then you go to enter the room unsuspectingly, you touch that door handle, you reach up to scratch your nose, or you go to get a drink or eat something, and then that's the mode of transmission. So not directly through the infected person, but they touched something, then you touched it. It can be in the air, it can be through direct contact, or it can be through something inanimate like a piece of furniture. So there's different modes of transmission. And then portal of entry. Normally our body has protective features such as intact skin that is a barrier to bacteria being able to enter our bodies. Our mucous membranes also serve as a protection, as sort of a barrier to, again, pathogens getting inside of our body and creating disease. But anytime there's a breach, so maybe there's contaminated food, and instead of avoiding it, we decide, it's probably okay that this pizza has been sitting out since yesterday. I'll go ahead and eat it. And then it enters your mouth, it goes down to your stomach, where then the pathogen starts, rebuilding its kingdom, and then you get sick. Breaks to the skin are another major portal of entry. So if you have a scrape, a cut, a burn, that provides an entrance for bacteria where once they may have been hindered. And then again, you're going to see that in wounds, in surgical incisions, that's often an area where infection can start. And then the last chain in this link is the susceptibility of the host. So anyone can get sick, but why do some people tend to get more sickly than others? Why might I get the flu as a healthy 40-year-old, but my 93-year-old grandma who gets the flu gets really sick and has to be hospitalized. That was the same virus that got into my body, that got into her body, but she became much more sick. Why is that? And so we're going to talk about that in subsequent slides. Now to get more into detail about pathogens, another term for that is infectious agents. So bacteria is the most significant of these. This is going to be the pathogen that we see um, most to blame among hospital infections. But of course, we also have viruses. Viruses are a lot smaller than bacteria, and these are kind of responsible for a lot of our flus. So we had coronavirus, the pandemic just a few years ago, and then of course this past flu season, flu A and flu B were definitely doozies, and those were all viruses. And then we have fungi, also known sometimes as molds, or another term, more common term would be yeasts, but that scientific term being fungi. And so, you can see this with a yeast infection, with some skin infections that are fungal in nature. So athlete's foot or tinea are some examples of common infections that we see. Typically aren't life-threatening, and if they're on the skin, generally tend to be more of a nuisance than a serious condition, but can be problematic if they were to become systemic. And then parasites. Parasites are a little bit different because they don't so much cause disease as pirate your nutrients. So it's a living organism that lives either on or in the host and then gets its nutrients from the host. And so in the context of nursing, when we talk about parasites, a picture I have here on the bottom right shows a helminth, which is a worm. And so you can get intestinal worms that reside in your gut. Usually that's from eating contaminated food or drinking contaminated water. And those worms can grow to quite a long length and really create a lot of stomach problems and eat really your nutrients. And so that can be problematic. On a smaller scale, we could have things like a tick or lice that could be considered parasitical. And then I want to mention one other category of infectious agents, and that's prions. And these are tiny protein particles. Now, this is still an area of research within the scientific community, and it's not well understood how these create disease, but we do see them implicated in some things like Creutzfeldt-Jakob disease, which is commonly called mad cow disease. And it originated in cows, but then crossed over to humans, and it caused sort of these vague neurologic problems that they don't really have a test for and are really diagnosed after the person has unfortunately been deceased. So that's an area where hopefully over the course of your careers, more information will come to light and you'll be able to learn more about that. But that's really all I have for it right now. So in the speaker notes on this slide, I do have some examples, and your book also provides more examples. And these are terms that you'll need to become familiar with. So what are some common bacterial illnesses? What are some common viral illnesses? Some of these may sound very familiar, like flu, but we also need to think of non-familiar examples, or if you're not in the healthcare world already, all of these may be unfamiliar, but I've got some listed for you. So under the viral category, HIV, herpes zoster, which is shingles, hepatitis, COVID-19, and rabies also would fall under that. Under bacteria, the biggest one, and we're going to talk about this soon, is C. diff, but we also have Staphylococcus aureus infections, commonly referred to as staph infections. Tuberculosis would be another one, and then we have bacteria in our gut called E. coli, and that's often the causative agent for urinary tract infections. And so again, become familiar with this. This is a whole nother language, but one that will need to become second nature to you in your nursing career. On this slide are some terms that will be on our terms quiz for this week. Common healthcare associated infections. And there's lots of acronyms in healthcare, and this is one of them. Healthcare associated infections, sometimes referred to as HAIs. And then as you'll see below, a lot of these infections have their own acronyms. So CAUTI, C-A-U-T-I, means catheter associated urinary tract infections. So in Concepts 3, you'll learn how to insert a urinary catheter, and that needs to be a sterile procedure. But what happens when that sterile procedure isn't performed up to par is that the person with the catheter can develop an infection in their bladder. Sometimes that infection can travel to their kidneys, and that's quite a serious event for the person, and has a lot of implications for the nurse who didn't follow sterile technique. So that's a big deal. And in the hospital, we refer to that as a CAUTI, catheter associated urinary tract infection. It's kind of a mouthful. Surgical site infection is another category of healthcare associated infection. And again, this is pretty self-explanatory. Someone goes to have surgery, and instead of being a sterile procedure, there's some kind of breach at some point, and bacteria enter the incision site and create an infection there at the site. Now, we hope that the infection, if it happens, remains limited to just the surface of the skin, but the fact is, if this is a joint replacement, like a shoulder, knee, or hip replacement, and that joint gets infected, the person will likely have to go to surgery again, get that replacement joint removed or washed out, and then have to go through that surgery all over again. So again, this is a big deal. Next one down is CLABSI, central line associated bloodstream infection. And a central line is similar to an IV, where you would get fluids and medications while in the hospital, but instead of being inserted peripherally in your arms or in your hand, it's inserted somewhere maybe on your upper chest or upper arm, and it goes straight to a large blood vessel near the heart. So again, this is a big deal if that site gets infected, because it has serious implications for that person's health, and again, for the nurse that's taking care of the site. And then some agents. So these bottom two are bacteria that are resistant to a lot of the treatments that we have for them. And so when a wound gets infected with these, or when a person's GI tract gets infected with these, that again creates a really severe illness for the person and is really hard to treat. And the first one is MRSA, methicillin-resistant Staphylococcus aureus. So we usually just say MRSA. And then Clostridium difficile, which is often shortened to C. diff. On this slide are just a few more examples of drug-resistant organisms that can create infections. All right, now if you'll remember back to the chain of infection, we had one of the links being the susceptible host. So when we talk about the host and why some people are more prone to getting sick or get more seriously sick with an infection, there are some factors to keep in mind. First of all is the number of organisms the individual was exposed to. Did they get exposure to just 10 bacteria, or was it 10,000? That definitely makes a difference in our body's ability to respond effectively. The next factor to consider is the pathogen's virulence. Now, this is one of our terms for this week, and this simply means the ability of the pathogen to invade the host and cause disease. Some types of organisms are just better at this than others, and others sort of act like they don't really mean it. Like, I'll make you sick, but I'm not going to try very hard. And so just the virulence of the pathogen does make a difference. Now, we have some pathogens that are extremely contagious and extremely virulent. And so, for example, Ebola would be one that if you get it, your chances are not good. Chances are that you're going to die from that, even with the best medical care in the world, because that organism is just so strong, it can make you just seriously ill. The next factor is the competence of the person's immune system. So how robust is that person's immune system, and do they have any conditions that would cause the immune system to be weakened? So for example, if you have a cancer patient who's receiving chemotherapy that suppresses their immune system, you're going to see that those people have to be super careful, because contact with any type of pathogen could make them seriously ill because their immune system is low. Another factor could be someone who's on immune suppressant drugs, who maybe has an autoimmune condition, or very young individuals like infants, especially under 3 months of age, or very old. So the very elderly are also considered fragile. And those two themes of extra care and caution with the very young and the very old, that's going to persist through a lot of your nursing training. So when we talk about pharmacology, when we talk about the immune system, when we talk about the GI system, when we talk about skin, when we talk about kidneys, again, you're going to see with the very young and the very old, those are often patient population segments that need special consideration. All right, and the last factor that's here on the slide is just the length and then intimacy of the contact between the person and the microorganism. So again, did you happen to walk by someone who was sick while you were in the grocery store and that was the extent of your exposure, like 10 seconds while you both picked out ice cream from the freezer aisle? Or is it someone that, shares your home, shares your desk at work where you sit next to them for hours each day? So again, we have the length of time and just kind of the proximity to the person that can also play a role in whether or not you will get sick. Again, some of our terms for this week. So what's the difference between endemic and pandemic? That's explained right here. And your book does contain more information on this. And this is a concept that you will continue to really drill down into when you get to pathophysiology. All right, so methods of transmission. Direct contact is the method of transmission that involves some kind of person-to-person touch or person to object touch. So if I'm touching a person's infected wound, again, that pathogen can get right onto me directly. If you're kissing someone who's sick, again, direct touching, exchange of saliva, contact is happening, transmission of the pathogen is happening from one individual to another, and we're going to see the same thing with sex. Now, it's important to note that needle sticks also fall into this category. So if you have given someone an injection and then you lay that needle down instead of disposing of it in a sharps container, and then later on you put your hand down and ouch, oh man, there's the syringe and the needle, I forgot I left it there and now it's pricked me and it's punctured my skin, that is a method of direct contact of potentially those few droplets of blood that remain in the syringe and needle and that now have gotten through your skin and into your body. The other methods of transmission could include indirect contact. So a vector would be, for example, mosquito is a great example. We're going to see that things like malaria can be transmitted via mosquito, where it bites someone who's infected and then it flies around and then it finds another live person to bite and get blood from. And then in that process, you have had the transmission of someone else's pathogen to you. And then fomite, this is kind of a funny word, but it simply means an inanimate object, something that's not alive. So this could be a piece of furniture in the patient's room, their bed, the IV pole, a computer keyboard, etc. And then we have droplet and airborne. These two often get confused, so do pay attention to the difference between these. Droplets are these larger particles, and when someone sneezes or coughs, out comes that explosion of these droplets of mucus that are nasty, and they go out about 2 to 3 feet in front of and to the side of the person, and then gravity takes them, they fall down to the floor or to the table or whatever's in front of the person. And then airborne particles, these are really small particles. They may not be visible to the naked eye, but they're less than 5 micrometers, so very tiny. And because of their small size, pathogens that fall into this category are able to remain suspended in the air and float around sort of in the breeze. And so there is more possibility for transmission, and we have to be more careful as nurses if our patient has a pathogen that can be transmitted through an airborne method. We are going to learn in lab this week that we have to take special precautions that are a little more uncomfortable for us, but ultimately serve a good purpose to keep us from getting sick. All right, now under factors affecting risks for infection, the big one I want to point out here is inadequate hand hygiene. This is such a basic skill for both us as nurses, but also for patients and for their caregivers, for their families, and just really everyone in the world. But as nurses, we are educated to know the risks, and yet studies show that still hand hygiene being inadequate is a common factor in hospital associated infections. And that's regrettable because as nurses, we can and we should do better. And so this is going to be one of our lab skills this week where we talk about hand hygiene and what that looks like. And then we're going to start putting it into practice. So from week 1 onwards, we are not going to be slackers. We are going to practice at the top of our abilities, and that includes performing hand hygiene frequently and professionally in a proper way that's actually effective. Okay, some other factors here though, again, compromised health. If someone has a suppressed immune system, has some kind of autoimmune problem, or is on medications that can affect their risk for infection. Age, remember the very young, very old, and then living conditions and lifestyle. We have to include this because it's so true. Our patients who do not have the means to afford an energy bill are not going to be able to maybe have hot water for hand hygiene or for showering or for keeping their environment clean, and that can affect their health. People who live in crowded quarters, again, finances is a big part of that. Can you afford to live someplace where you have adequate facilities or adequate space, or do you not have a choice to remain close to someone who may be sick and unwell and who you would distance from if you could, but due to the financial strain, you have to remain living with them. So those are factors that also, put our patients at risk. And so it's easy to be judgmental and think, why is this person sick? Why couldn't they have done anything to prevent it? But if we look at truly the reasons why, so often it's things that are outside of that person's control, and things like social determinants of health, finances, culture, all of those play a big role in risk for infection. So that concludes our background on infection, and now we're going to move into inflammation. So what happens when our body is exposed to a pathogen? Or it could be to stress, but specifically within the context of this week's material, we're going to talk about what happens when our body is exposed to a pathogen. So first we have this inflammatory response. And if I asked, is inflammation good or bad? I think I would get mixed answers, with some people saying, well, maybe, some people saying, no, it's not good. And a lot of times inflammation gets a bad rap because we think, oh, inflammation, that's a problem. I need to not have that. But inflammation, when it occurs naturally within the body, can be very helpful. So again, it can be infection, it could be injury, but it's a response by the body to bring extra blood flow to an area that needs it in order to bring cells for healing, cells for fighting infection, in order to kind of scope out what is the problem and how can I respond, and then to rebuild afterwards and clean up dead cells, repair tissue. So inflammation isn't bad unless it's out of control. There's a really great video in your course resources, and I would recommend watching this. It's not by me, so you won't have to keep listening to me, but it does go into kind of the cellular, what happens on a cellular basis with inflammation, and can help you have a really robust understanding of this concept. Stages of infection. This is one of our key concepts for this week. And we have these 4 stages. The first stage is the incubation period. So in this stage, the pathogen has gained access to the body and it starts growing and multiplying. Because there might only be a few pathogens at the beginning, typically the individual doesn't feel sick. They feel fine. But really what's happening behind the scenes is that the pathogen is multiplying, or it's getting more and more populous within the body, and it's only a matter of time until the prodromal stage starts. And in the prodromal stage, that's just when the person first starts feeling blah. They don't feel great. They don't really have anything specific, but they may just feel tired. or just like I'm kind of nauseated, I don't feel good, but they don't really know what's wrong. Sometimes it's easy to dismiss as I'm just, I need to go take a nap or I'm just stressed, but this could be the first sign of illness. Then in stage 3 is a full stage of illness, and that's where specific signs and symptoms start. Like, oh my goodness, I started vomiting and I had diarrhea and I have a fever. Those are very specific symptoms that a person can have that kind of point them to what type of illness it is. And then in the convalescence period, convalescence, I love that word. It's kind of an old-timey word and it just means recovery. So in the convalescence period, the person's starting to feel better, and this usually occurs over the period of several days to several weeks, depending on the infection, where the person gradually returns to their normal self. Okay, now when we have infection, what kind of signs will we see in a person's laboratory results that could clue us in that there's an issue? This is something that you'll continue to build on throughout your learning in concepts 1, 2, 3, and in pathophysiology, but we're going to introduce it now, even in concepts 1, so buckle up. A CBC, this means a complete blood count, and what we'll see is this is just kind of a basic lab test that can be done to indicate how many red blood cells, how many white blood cells, etc. are in a person's body. And with the presence of an infection, you'll often see that the white blood cell count is elevated. So there's the normal range, and then it goes above it, so greater than 10,000 microliters, and then that could indicate, aha, it's an infection. Now, there is a different type of CBC that can be done. It's a little more specific, and it's called a CBC with differential. And so with the CBC with diff, as sometimes it's shortened to, you'll see that the different types of cells, the white blood cells, can be broken down into their categories, where instead of just getting that overall count, you're seeing specifically these different types of white blood cells. Maybe the monocytes are elevated, or maybe the neutrophils are elevated. And for trained clinicians, this can indicate, is this infection a short-term problem, or has this been going on for a long time? Another lab value that you might see assessed is an erythrocyte sedimentation rate, sometimes shortened to ESR. And when this is elevated, this can also be an indicator of infection or chronic inflammation. And then lastly, but not least, cultures. So as nurses, we're often directly involved with collecting cultures. And a key takeaway with cultures is that they have to be collected before the first dose of antibiotics. Otherwise, what will grow in the culture otherwise may not grow if the person's had antibiotics on board. So with a culture, what happens is there's some sort of little sample, and this could be urine, blood, sputum, anything really. Could be drainage from a wound that we put on some kind of petri dish, and then it's grown in the lab. So we let that grow under favorable conditions, and we see what kind of bacteria sprout up. And then we bombard it with different types of antibiotics, and we see, okay, well, there's the bacteria that grew, and look, this antibiotic killed it really well, but this antibiotic over here, it didn't do much. So let's not give the antibiotic that didn't work. Let's give this one that seems to be working really well against this specific bacteria. So culture is really important, can be a really specific tool to use in fighting infection. Beyond labs, what are some specific physical signs we'll see when assessing our patients who do have infections? The classic fever, have it highlighted here. This is often an early symptom, but one that indicates there is a problem. Some other things that we might see are listed here. So an elevated pulse and respiratory rate. Sometimes if it's an infection, let's say at a wound, the wound is going to feel kind of hot and maybe look red and angry. It might hurt a lot or be swollen. And then there's some other things. Again, depending on the type of infection, if you have food poisoning from infected food, you're going to see different symptoms than if you have a lung infection from pneumonia. So different types of infections will produce different symptoms. But the key is we're going to see those bodily symptoms and then tie it back to a specific organ or a specific body system and be able to narrow down the cause and then the treatment. Remember, older adults and babies are going to have symptoms when you assess them that are a little bit different than common symptoms of infection, so do pay attention to how that is different as noted here on the slide. And then on the next slide, we're going to talk about exudate. And what that is simply drainage from the body. And we can assess this and then document it appropriately. And there are some fancy words that we use. One of the terms is called serous, the other one is serous sanguinis, and then the last one is purulent. And what we'll see is that the last one, purulent, is really pus. And so it can be a green or yellow drainage. It's kind of thick. And when we see that, we do know, oh, something has happened. This isn't normal. And this can be a sign of infection. Serous drainage can be described as simply clear and sort of yellow in nature. Serous sanguinis means it has that clear fluid, but there's also either a pink or a red tinge. And you can see that in this picture here on the right. And then that last word that we used for the drainage, purulent, is seen here in this image on the left of this foot that looks infected. Maybe this individual stepped on a nail or a rusty garden tool, and then this area has gotten infected and it's got that drainage from it. Believe it or not, we as nurses are mandatory reporters, and not just for things like abuse, but also for infectious diseases. The CDC maintains a current list on their website of diseases that need to be reported. Some of these are on a weekly, some of them are on a monthly basis, and some of them on a yearly. But some examples listed here below are TB, rabies, hepatitis A, and there are many, many more. You're going to follow your local state guidelines for this, as well as your organizational policy. So again, when we practice as nurses, it's important to know, yes, how to do the skill, but then also where to go for resources on legal matters like this. The prodromal stage is the stage of infection in which the patient is actually most contagious. So this is that stage where the person initially gets some vague symptoms of illness, but doesn't usually have the specific symptoms like fever or vomiting that would cause them to stay home. So because they're still out and about, but they are infected, this is a stage where they can spread that disease the most. To review, for the chain of infection, we have to have the infectious agent, that pathogen. There has to be some sort of reservoir where the pathogen resides. There's a portal of exit, a way in which that pathogen emerges from the reservoir, a means of transmission, and then a portal of entry. There have to be susceptibility issues with the host, so different factors that can cause people to get ill. And then it kind of starts all over again with once another person becomes ill with an infectious agent, they become a new reservoir, and that cycle goes on and on and on. I love this image because along each link in this chain, it shows how different types of nursing actions can impact and break that infection cycle. So if there is an infectious agent, we can use different things like hand hygiene, sterilizing equipment, giving antibiotics to eliminate that infectious agent and keep it from just turning into an endless reservoir of infection that can spread to others. And then at the reservoir level, we can contain it and keep things from exiting by, using precautions, disposing of devices. And so take note of each of the scissors markers here along this chain and see what actions we can do as nurses to break each of these links in the chain of infection. You're going to see that hand hygiene features heavily in pretty much every link in this chain. So that is the foremost method of breaking the chain of infection, is through practicing meticulous hand hygiene. Standard precautions, sometimes called universal precautions. These are precautions that we as nurses use in the care of all hospitalized patients, regardless of their diagnosis or possible infection status. And this is not just nurses, but really anyone who works in healthcare, physical therapists, doctors, PAs, nurse practitioners, radiologists, etc. So with standard precautions or universal precautions, the idea behind it is that any kind of bodily fluid or secretion is considered potentially infectious. So everything except sweat. So anytime we're touching any kind of bodily discharge, we're going to wear gloves. And anytime you touch non-intact skin, so that could be like a blister or a burn or a scrape or an incision, and anytime we touch mucous membranes, so the mucous membranes are the inside of our mouth and nose, our eyes. So anytime we touch any of those, There are some things we need to do to protect ourselves from people's, saliva, from their vomit, from their urine, from their fecal material. And typically that looks like gloves. There are some other things that feature in standard precaution, and that's practicing respiratory hygiene or cough etiquette. So this became very popular during COVID, where we saw signage up everywhere: cover your cough, dab to fight COVID. And the idea is that if you're coughing, go ahead and put on a mask, cover your cough. If you have to blow your nose, dispose of that tissue right away, and then clean your hands. So those are simple things, just simple etiquette items that anyone can do, but especially we as nurses need to model to our patients in practicing safely for ourselves and for them. Another component of standard precautions is practicing the injection giving safely. So what do we do to prevent ourselves from getting a needle stick? What do we do with our sharps when we're done with them? How full does a sharps container need to be? And so, for example, OSHA regulates these a lot, so this is going to tie into our legal lecture, but sharps containers can only get about 2/3 of the way full before they are considered done for, and we need to dispose of them. If a sharps container is overflowing and you're trying to mash yet another needle into it, there's a risk that you're going to jab yourself with a needle that's sticking out of it. So again, don't wait till it's full. Go ahead and call for it to be replaced when you see that it's starting to get full. And most needles nowadays are going to have safety devices on them where as soon as you're done injecting, you either push a button or you flick a switch and a sheath will cover that needle tip to prevent it from stabbing either the patient or you or a coworker. And speaking of someone who has had a needle stick injury at work before due to a coworker leaving their needle out and uncapped and unattended, I feel really strongly about this and how we need to practice safely, again, both for ourselves, for our patients, but also for the safety of our team. Thankfully, the person didn't have anything that made me ill, but that was definitely a scary moment in my practice. And then lastly, under standard precautions, the last item is safe handling of laundry. And this seems so simple, but this is truly a way that we can keep from spreading someone's pathogens onto someone else. So if there are soiled linens, and that could be with urine, again, with any kind of bodily excretion, we need to, as nurses, often change these. And when we're handling them, we don't hold them up close next to our body where those pathogens are getting all over our scrubs. We're holding them away from our body, and then we're putting them directly into some kind of bag in the room. We're not toting them around the hallway looking for the linen hamper. We're going to bring that linen hamper to the door and toss them right in. Or if they're really damp, we're going to put them in some kind of plastic bag, and then follow our organizational policy for linen laundering. All of these are components of universal precautions. I do want to add, it's important to note that if you expect splashes throughout the course of just standard care, it would also be appropriate to go ahead and put on maybe a face shield, a mask, or goggles. So if you're doing a procedure like wound irrigation and you're exercising standard precautions, and you expect that there might be a little bit of splashing of some infected drainage from the wound, it would be appropriate in standard precautions to go ahead and put on something to protect your eyes and your mouth, and that would still fall under the standard precautions umbrella. Everything on this slide is highlighted because this is one of the main skills for this week. So under standard precautions, the big one is hand hygiene. It's important to note that hand hygiene has two components. So that could mean either hand washing with soap and water, or using an alcohol-based hand rub, so hand sanitizer that you would squirt into your hands and then rub together. Alcohol-based hand rub is the preferred method for killing just pathogens in general, unless there's a few exceptions, so please note these. If it is a Clostridium difficile infection, so we mentioned that earlier in the lecture, but if a person has C. diff diarrhea, that is not appropriate for the alcohol-based hand rub. that type of hand hygiene does not kill the spores that cause C. diff. And so we do need to actually physically wash those off with running water and soap. So soap would be the preferred hand hygiene method with a patient who has C. diff. And then the two other times would be when your hands are visibly soiled. So something actually like, patient throws up in your hands. How gross would that be? Hand sanitizer isn't going to cut it. You do need to actually physically wash them under running water when they're visibly soiled. And then before and after eating. So hand hygiene can include either hand washing with soap and water or use of alcohol-based hand rub, and both of those fall under that hand hygiene umbrella. And hand hygiene is the number one best practice to do to stop the transmission of infection. So more powerful than anything else we have at our disposal is simply hand hygiene. I cannot say it enough. Hand hygiene, hand hygiene, hand hygiene. And if you are stuck on the test and you don't know what to pick, hand hygiene. All right, next slide. According to the World Health Organization, there are 5 key moments for hand hygiene. And of course, any other time you add it, like I said before, you cannot do it enough. So hand hygiene, but these are the 5 key moments. Moment 1, before touching a patient. Moment 2, before you start any type of clean or aseptic procedure. So before you put on those gloves, go ahead and get some hand sanitizer, clean your hands. Before you start a sterile procedure and put on sterile gloves, go ahead and clean your hands. All right, moment 3, after any type of body fluid exposure risk. So you've helped your patient up to the bathroom, you were wearing gloves, you helped them wipe their bottom, get cleaned up, get back to the bed, or maybe you changed a dressing on a patient's leg and you were wearing gloves and you felt like you were pretty careful, but there was still a chance that, what if there was a micro hole in those gloves? There was any chance that you could have been exposed. After you remove your gloves, you're going to go ahead and wash your hand. And then moment 4, after touching a patient. So remember, sweat alone is not considered to be infectious. So we may touch someone, maybe we're holding a patient's hand or helping them wash their hair or, handing them supplies. But we do want to wash our hands afterwards. And then moment 5, after touching a patient's surrounding, remember, fomites, those inanimate objects like bedside tables and railings and doorknobs, those can all contain pathogens. So after touching anything in the patient's surrounding, it's a good time to wash your hands. So when should you wash your hands? All the time. The answer to this question is that yes, numerous studies show that alcohol-based hand rubs are more effective at reducing bacterial and viral counts on the hands of healthcare personnel compared to antimicrobial soap. So yes, it is the preferred method of hand hygiene. Transmission-based precautions are special actions that we take as nurses in addition to standard precautions for patients that have certain infections. So this would be infections that could be transmitted by either the airborne, droplet, or contact routes, and you're going to see that the transmission-based precautions kind of match those terms. They can be used alone, or you may see a combination. So it is assumed that standard precautions is for everyone, so we don't ever say that, but you may have a specific physician order for droplet and contact precautions for this patient. Or maybe the order simply says contact precautions, or it may say contact and airborne precautions. So you can see there can be some variations, but let's talk in the subsequent slides about what those look like. A few examples here of different diseases that would be a causative factor for this type of precaution being ordered. So for airborne, TB is a big one, tuberculosis. So oftentimes that's shortened to TB. Measles and varicella. Varicella is chickenpox, but that would actually be considered an airborne illness. Strange, right? But you'll get into it in patho. But these patients are going to need a private room, so preferably their own room, not roomed with another patient. They should be able to close the door. Sometimes, if possible, we might put in a negative airflow system or have a HEPA filtration device to filter out the air that's potentially coming in and out of these rooms as people enter and exit, to keep that airborne illness from floating down the hallway and getting onto other patients. As healthcare workers, for a patient who has airborne precautions ordered, we need to wear an N95 mask, and we'll practice this in lab. Now, if you have facial hair or can't get a good fit with the mask on your face, you may have to wear a what's called a PAPR respirators, and this kind of looks like a little space hood where it's got a little breathing tube connected to a pack, and then the hood goes over your whole head, and what that does is like filters the air that you're breathing in. And the key to note with either one of these is that you'll put this on before you go into the room. So you don't wait to enter the room and then try to figure out, all right, I'm going to hold my breath while I put on my mask. You're going to put on your mask and then take the steps, towards the door to go in. And when you exit, also that's going to be the, last thing to come off, as you exit the room and are then out in the hallway, then you'll take that off, not in the room. Okay, for a patient with droplet, so this could be flu, that's a very common one. Pneumonia is often on a droplet precaution, or pertussis, which is whooping cough. Again, common illnesses that result in droplet precautions being ordered. These patients typically are going to have a private room, or if they have to share a room with someone, it should be someone with a similar illness. So hospital might be at full capacity, they may not have enough beds, and they say, who can we room together? They might put 2 flu patients together because they both already have it, so they're not going to get each other sick. They're both already sick. For these patients, as nurses, we're going to exercise, remember, universal precautions, but then we additionally would wear a mask anytime we're providing care to this patient. And then the last one is contact. So the big ones that cause contact precautions to be ordered, this would be C. diff, so that infection that causes terrible diarrhea. MRSA, and this is often seen in wounds, or VRE, again, often seen in our very sick patients, and this is a resistant bacteria. So we do need to take extra precautions for these patients. And so this would include gown and gloves, any visitors that come in and out, so even if they're not healthcare workers, should be trained to put on the appropriate precautions. And then you need to have dedicated equipment, so a dedicated stethoscope and a dedicated IV pump, and anything that you bring into the room, you have to go into it with the idea that I'm leaving this here. This equipment is not coming out until either this patient gets better or they pass away, because this equipment is now kind of stuck to that patient. Just a little reminder that the best way to prevent the spread of infection is by, when in doubt, go with hand hygiene. This may seem like a trick question, but the question says, should standard precautions be used when caring for a non-infectious post-operative patient who is vomiting blood? So this person had surgery, and then now you're caring for them and they start vomiting and they have blood. What kind of precautions should you use? So take a moment and think, is this universal precautions only? Is this universal precautions plus droplet? Is this universal precautions plus contact? What is it? And the answer is that yes, standard precautions is actually what should be used standalone. It doesn't need anything else added. If we do expect that there might be splashes from this person vomiting blood and that vomit splashing up, it would be appropriate under standard precautions to go ahead and put on maybe a face shield or a mask and goggles. All right, and now we're winding down with our concepts for this week, but we're going to talk about the difference between clean technique and sterile technique. Asepsis is just a fancy word that includes, activities that prevent infection or break that chain of an infection. So clean technique, this is what we use with standard precautions. So hand hygiene, again, is that big one. You're going to see that featured here, and it's even highlighted for you. And then things like wearing gloves, cleaning our stethoscopes in between patients. Those are things that we do to just maintain clean technique. When you're giving someone an injection or preparing to draw blood, you're going to clean the skin at the site before you do it. And again, that's part of clean technique. We're not sterilizing the patient. We're not sterilizing our equipment, but we are cleaning it. Now, the higher level is surgical asepsis, and sometimes this is called sterile technique. And I do like the terms clean technique and sterile technique, so you'll hear me use those in our labs this term. So sterile technique is a technique used to keep the area in question free of microorganisms as much as possible. So there are a lot of things that we do as nurses that employ sterile technique. So this could be sterile wound care, putting in a catheter, or maybe doing a central line dressing change. And so typically your organization will have protocols for the steps that you need to follow, and you are going to learn a lot of these in our skills lab and get to practice them as student nurses. A few details, and this is a good time for me to talk about dress code for lab. So whether you're going to clinicals or coming to lab to practice, we do expect that our personal hygiene as both professional nurses and as student nurses is at the highest level. So we're practicing hand hygiene regularly. Hair should be pulled back if you do have long hair. Minimal jewelry, so this includes, studs in the ears. If you have large rings, it's recommended that you wear either no rings or something that has a low profile so it doesn't get caught on gloves or rip the gloves. And then nails need to be cleaned and trimmed and natural with no nail polish. Nail polish, especially when it chips, is a reservoir, there we go with our terms, a reservoir of infection for pathogens. And so that does need to be neat and clean. And then, of course, for lab, you're expected to appear in your clinical uniform with your student badge. So keep in mind these things, and in lab, we are going to practice as though it was a real life clinical, even though we do realize that the mannequins, they're not quite as lively as our patients in real life, but we want to start practicing even now in our pretend environment as though we're out in the real world. So please pay attention to these personal hygiene items when you come to lab tomorrow. Just a few practical tips here. Again, as you're starting your nursing, as you're starting your foray into nursing. Now, if you already work in healthcare, these may be sort of old news to you, but those of you who are already in healthcare or working as some type of healthcare professional, this is an opportunity for you to support your classmates who may not have a medical background and kind of help explain how and why these matter. Now, if we're talking about surgical asepsis or sterile technique, there are a few practices that will be a little different from just regular, be clean and neat. So it's important to remember airborne particles can contaminate a sterile field. So once you open something that's sterile, once it's exposed to the air, after a certain amount of time, generally the cutoff is about an hour, that sterile field is no longer considered sterile. So let's say you go in a patient's room, you open a sterile urinary catheter kit, and you're preparing to do this catheter insertion when suddenly you're called away to help your coworker. Well, that ends up being kind of a complicated case, and then it's time for passing meds, so you do all of that, and then you come back to where you had set up your sterile field. Well, if enough time has elapsed, that would no longer be considered sterile. And because you weren't watching it the whole time, it is also not considered sterile. So if you turn your back on the sterile field, if you're not watching it, who knows what has happened while you weren't there. Someone's kid could have come over and touched the items. A fly could have flown in and landed on them. A patient could have gone over and taken a look. So your eyes need to be on it. It can't be open for long. Only sterile items can be on or over a sterile field. And so this does include when you're working and you're reaching. This is a practice that takes some training and some mindfulness with where your body is. And if you're constantly reaching over your sterile field with your arms or with your body, there is the potential something could fall off your clothes, fall off your hair onto the sterile field and contaminate it. So a good practice is that try to reach into the sterile field from the side and only put sterile items over the field and onto the field. If you do need to add something to a sterile field, you need to have someone else with sterile gloves put the item on the field or use sterile forceps to move the item onto the field. So sterile can only touch sterile. If your hands are below your waist, like if you reach down to get something or drop your arms to your side, they are considered contaminated and not sterile. Or if you reach far above your head, again, that would be considered contaminated. So there's lots of do's and don'ts with the sterile technique, mostly don'ts. So, but learning this early on will really help you in your practice and keep you from a lot of heartache down the road in Concepts 2 and then in Concepts 3. Note, if you are adding items to a sterile field, you do need to drop it from about 6 inches above. And this does take a little practice because sometimes when you're dropping things, what's the risk? The risk is that it can sort of flop and then roll or bounce off the field or off the edge. And so this does take a little practice, and we'll practice this in lab this week. And then lastly, any type of non-sterile moisture does contaminate the sterile field. So if you open a kit and you see that it looks like it's been wet, but then it dried, or if something non-sterile like saliva or urine lands on your sterile field, again, contaminated, you got to start over. All right, and then wrapping up, we're going to talk about the nursing process. If you don't know what the nursing process is, this is a priority setting framework that we use a lot as nurses, and you'll hear a lot about it in the subsequent terms, and then use it into your practice. There are several pieces to the nursing process. The first one is assess. That as nurses, we're always going to start by assessing the situation. We're not just going to jump in and assume that we know everything. We're going to take the time to notice, and we're going to ask really good questions and listen to what our patients have to say. So the next one is diagnose, or sometimes this is referred to as human needs statement. So once we've taken a look at what the problem truly is, then we figure out what the person really needs. Then we make a plan. How are we going to meet their needs? And then we implement the plan. That one's the easiest because we're actually just doing the nursing things. And then we evaluate. Did that plan work really well? Is there anything that I would do differently next time? And did it help my patient? So when we talk about infection control, there's a few things we need to stop and look at before we get started with anything. So, I have some examples here, but this is by no means comprehensive. But is my patient allergic to anything? Maybe I'm getting ready to put on gloves, and this is something that we do a lot as nurses, but maybe I'm wearing latex gloves and the person is allergic to latex. Then I'm not actually helping them by wearing latex gloves. I'm doing something that could cause them to have a skin rash and then get infected. So again, stop and ask these questions before you get started. Some other things that we might assess is like asking the patient questions about, the history of their illness and, have they received any immunizations. We might assess their vital signs, and we're going to learn this in week 2 in this course. And so these are, again, not comprehensive, but just some examples of things we assess related to infection control. I'll see you in lab on Friday, and we'll practice assessing a few things as well as working on that diagnosis, human needs statement. What do our patients need? What kind of precautions? We'll work on actually implementing the skills and then evaluating did they work or not. So I look forward to seeing you in lab, and thank you for the listen.